back to Dr. Mudher. COPD exacerbations, the hidden drivers of disease burden. Please, Dr. Mudher.
يا شباب. Thank you kindly, Professor Abdul Hamid. Quite comprehensive overview of the latest guidelines to something so crucial, I think, just because of the burden of the disease that we see before us. So if you look at the diagram in the middle here, it's the third leading cause of death worldwide. يعني مو شقة موضوع COPD. يعني أتذكر أنا بالكتب دوم نشوف إحنا cerebrovascular disease, cardiovascular disease وmalignancy. هسه بدأ COPD صار هو malignant disease. زين, and especially in areas where infection is endemic and the context of people who have not just tobacco smoke consumption, but pollution, biofuels, lots of partial combustion of things within the environment, it will lead to a higher proportion of a higher prevalence of COPD. And that we need to do something, inshallah, مستقبلا in Iraq and some other neighboring countries to actually understand the burden of disease within Iraq itself, which I suspect on a global scale is an underestimate if we relate it to Iraq. And I think all of us feel that anecdotally when we have clinics, when people have a lot of features of COPD clinically, radiologically, via CT scan, and you feel that it's actually something that is untouched and needs a lot more attention. Almost 500 million people have COPD, 500 million بالعالم. And I always say that people who want to understand COPD very well, we go back to the internal medicine. You learn a lot about COPD, particularly inpatient COPD, if you cover medicine. ليش؟ لأنه about 30% of acute unselected takes in medicine is respiratory, most of which is COPD. That's why a lot of people with as internists have an interest in this, and that's why AstraZeneca insisted, not just with when it comes to the asthma component tomorrow, but COPD and other sponsors within this conference to add COPD to the mix. One of the other things as well that you have to remember with COPD is that COPD, if you look at the bottom there, is one, you can die of respiratory diseases, and two, you can die of non-respiratory diseases as alluded to. So the complications that you get related to COPD. And these include cardiovascular related causes. And COPD, as time has progressed, has now changed from something localized to the lung, but something systemic. And if you measure a lot of patients who have COPD with evidence of emphysema, particularly on imaging, what we used to call the blue bloater or pink puffer phenotypically, a lot of these people actually have systemic disease. The CRPs hover between 30 and 40 chronically. So it's a systemic disease. And there are estimates that almost half of patients with COPD are undiagnosed based on trajectories of snapshots of the population. This is interesting. So you've got these three famous studies when it comes to COPD: Spiromix, Uplift, and Eclipse. And you look at patients with COPD who experience an exacerbation. So if you have a diagnosis of COPD, a half to three quarters will suffer an exacerbation. And then when you've listened to Professor Abdul Hamid's talk and other talks coming, we know what exacerbation means in terms of risk to their prognosis in the future and their comorbidity. They, of course, have significant impact on patients. And the younger that they are, and the more that we're finding more and more COPD patients, the dyspnea, the 6-minute walk test, the desaturation that they have, the impact it has not only in them executing normal daily functions within their occupation. شوية شوية شوية, eventually, even their personal hygiene needs, إذا صار عندهم exacerbation, they will struggle with it. And when you have somebody with an exacerbation, so particularly if they've come into hospital, I always say that it's really helpful for me, not as a chest physician only, but as an internist, that these patients should have the following tests. And I think every patient, if you have the modalities available that gets admitted to hospital with a COPD exacerbation, should have an arterial blood gas. ليش? Why is it crucial? One, if they're in respiratory failure. Two, what type of respiratory failure they are. Three, if they have a metabolic component. Four, if they have type 2 respiratory acidosis, and or they have decompensated type 2 respiratory acidemia. What's triggered this? Is it a metabolic thing? We look back at the bicarbonate. Or is it something that's not obvious, like sedation or pneumothorax or infection? Could it be a PE? Could it be an MI? So the blood gas actually gives you a lot of information. And one more thing, particularly in more advanced blood gas machines, they give you the carbon monoxide. So it tells you whether people are likely to be still active smokers, active passive smokers, or they're exposed to biofuels or partial combustion. And carbon monoxide poisoning is underestimated, and quite often we underestimate it. And some of them will have a headache, which we relate to the carbon dioxide rise, but not necessarily. Blood tests, urea, electrolytes, particularly in the context of infection, they're looking for the urea. A low creatinine in somebody in the old-fashioned phenotypic pink puffer indicates that their nutrition is not up to scratch. C-reactive protein, there's been a few studies that show that neutrophils lag behind, or if somebody's had over-the-counter systemic steroids, can confuse the issue a little bit when it comes to neutrophils. Either they're high because of steroid use, you're not sure. So CRP is helpful only if you've got a baseline CRP. So if somebody's had a chronic COPD and the CRP is between 30 to 60, it might not necessarily be that significant. But if it's something much higher, it does indicate underlying infection. And interestingly, you can also get significant CRP rises in SARS-CoV-2 and other types of, and other non-pneumonic lower respiratory tract infections within COPD that are bacterial. You get a really high CRP. That usually is an indicator for antibiotics. فمن أقول non-pneumonic يعني جوا الأوتار الصوتية and there's no parenchymal consolidation. دولة they're severe. وراح نعرف شنو impact on mortality in the future if they have productive cough. ECG, you'll see again, really crucial. Then it gives you a baseline commonest reason why people develop COPD, smoking, صح? فمعناها we need to look at other things that smoking does, including changes to the ST segments, for example, that give you a signature of previous problems with the heart. A chest X-ray, bread and butter of plain, is so crucial. Somebody with a COPD exacerbation, جريمة if they've not had a chest X-ray. And then based on clinical presentation, EVTS, extended viral throat swab. The state-funded institutions like the NHS is quite generous. Sometimes they even give you stuff like mycoplasma and other stuff. In Iraq, it's a bit more tricky because it's limited. There's point-of-care viral testing in the private sector, and they don't upgrade depending on strains that are changed in terms of viruses. And in the private sector, to have the equivalent of an extended viral throat swab that I think we're used to in the UK, I think out of pocket, the patient would be about 300,000 Iraqi dinars short. It's quite expensive, so it's about 150 quid. D-dimer assay, depending on the clinical context, of course, may be helpful. Troponin may be helpful. Those two, particularly if, like I said earlier, somebody has decompensated type 2 respiratory failure and you can't find an obvious cause. There's not really that much in the way of infection. They've not had sedation recently, and they've not got a pneumothorax. Think about those two. When you look at patients with COPD, this is one of the issues that I think we underestimate. And I think it's still in the investigational stage. The way that we risk stratify people who are at risk of cardiovascular events, personally, I think people who have COPD based on evidence, because they have 280% increased risk of cardiovascular events, because the risk of death increases by 80%, 80% of patients with COPD who have 2 moderate exacerbations within a year. To me, I think COPD should be a cardiovascular risk factor. The problem is that what is it that might actually lead to a cardiac event? Is it type 2 MI? So they have existing atherosclerosis without a ruptured acute plaque. And because of the hypoxemia and the overwhelming stress to the system, they've developed what we call type 2 MI, which doesn't require percutaneous coronary intervention. And you could argue you need studies to justify antiplatelet therapy, dual antiplatelet therapy, and statin for all those patients who have severe COPD who've suffered from exacerbation. هاي احنا ذكرنا شوية على symptoms. This forest plot, interestingly, shows that people with frequent productive cough compared against those who haven't are twice as likely to develop an exacerbation of COPD. The good thing about it, inshallah, I say, these are the patients اللي احنا نحب نعطيهم low dose macrolide therapy. So those that have chronic bronchial sepsis, about 2/3 of them, you will see a response within 2 months, as long as if you give them warning signs about the low dose macrolide therapy. But these are the ones that are at risk of developing further exacerbations, further cardiovascular events, etc. So if they've got a frequent productive cough, don't underestimate the risk in the future for that particular individual COPD. One of the problems I think that we've had, and I don't think it's unique to COPD, بس شي يصير من واحد يصير عنده مرض مزمن when you get chronic ailments, you get bored, مو? Because your expectation is different. You don't want to be a burden on your family. Oh, هم تنقت. Oh, تنقت means oh, you're still breathless. تنقت هاي عراقية لك إيهاب. حطها باللستة. زين. هو هسه إيهاب أحلى شيء عنده لحد الآن شكو ماكو. الكل على شكو ماكو. So basically, people who've got COPD exacerbations, a lot of them get to a point where their threshold for seeking advice, seeking help changes. So a lot of it goes unreported, but then of course they're at very high risk when they do eventually come with a COPD exacerbation, because they only come now when they're really, really bad. And you have to remember that patients with COPD who are susceptible to exacerbations and got a history of exacerbations, 1 in 4, يعني 25%, 1 in 4 of those patients with 2 or more exacerbations did not have a recent exacerbation history. يعني the premise احنا هواي مرات نقول جاية رايحة كل ساعة جاي وراجع. No, it's not true. اكو ناس they can be 2-3 years completely symptom free. They've stopped their smoking a long time ago. They're still 1 in 4 are very high risk of developing 2 severe exacerbations. It's just because their reserve is different, especially if they develop quite a tenacious viral infection. This is what I call the broad complex tachycardia of COPD. So we see on the y-axis is the rate of next severe exacerbation or death per 10,000 patients per day. هذا y-axis. والx-axis is the time after the first severe exacerbation. فبلوى يبتلي أبو COPD. If they start exacerbating and we don't optimize their treatment, when we don't offer them مثل ما تفضل استاذ عبد الحميد, and I think we all نقصر بموضوع الvaccinations, المتابعة, trying to develop pulmonary rehabilitation in the future, readily available for these patients, making sure they're protected from all of this, يصيرون كأنهم broad complex tachycardia مثل توسيادة دبوا or narrow complex tachycardia. You see that the proportion of them that will develop a severe exacerbation, the time is shorter, yeah, after the first exacerbation, and they're more likely to die. يعني كل ما يصير exacerbation يصير الحلقة المفرغة مالتهم that they would struggle to come out of. فهذا this is quite a powerful graph in terms of people who suffer from severe exacerbation of COPD. وحدة. 2. One of the other issues of severe COPD, العفو مو severe, كل COPD exacerbations, لما الواحد they drop their lung function, a lot of them take about 10 to 12 weeks before they get back to their baseline function. وترى مريض, if we have a patient who's like hovering about the place with about 990 mils, and they walk about like this, ويوقف pursed lip breathing حتى يزيد البيب positive expiratory pressure. If they get an exacerbation, they really struggle, because if they lose about 200 mils, 150 mils for like 10 weeks, that is a massive loss of lung volume. So they've shown in this that a lot of these patients take a long period of time or may never regain their baseline function. اللي نأكد ليش لازم واحد ضروري when you recognize that they've got COPD كلش نتعب عليه حتى نتأكد ماكو comorbidities أخرى, compliance to treatment, ماكو smoking environment, etc. شكو شيء نقدر modify حتى نحميهم. بعد اليوم أنا كلها أخبار سيئة وباد نيوز كلش بالنسبة COPD. من نجي in terms of dropping of what their lung function is, همزين الحمد لله, the ones that have severe, they don't have much more to lose خطية. They generally they lose less lung function compared to those who've got mild. In mild, they've got a lot more to lose. But when I was looking at that study, to be honest, in fairness, I don't know whether that 20 mils is an underestimate because some of them died. For the ones that survived, طبعا they only dropped by 20 mils. So I don't think it was modified for that, but I need to double check as well. I'm not going to go into too much detail about how much they increase the cardiovascular risk. I think it's evident, and it's being covered by colleagues as well. But there's a massive, true correlation in terms of risk death from cardiovascular disease, whether it's atrial fibrillation with rapid ventricular response and the patient becomes compromised, a myocardial event, etc. وشكرا جزيلا.